There we go. All right, so let's start with a couple of questions again this time to set the frame. So this is a 36-year-old man presenting with dyspnea and exertion for the past 6 months. Worse when it's warm and following meals. He's got left ventricular hypertrophy with a wall thickness of 24 millimeters. He has no systolic anterior motion or outflow tract obstruction. Rest of the examination is unremarkable except for the murmur, which increases with squat to stand maneuver. So the next question I'll show you on the next slide is management. So what should we do next for this individual? New symptoms. Should we get a cardiac MRI? Should we do echocardiography with provocation? Do a hemodynamic cath? Or get a transesophageal echocardiogram? Audience says, okay. And the next question is a 64-year-old woman, prior history of hypertension. She has new onset dyspnea that's class 2. Vital signs are there. She's on amlodipine, metoprolol, and aspirin. She has septal thickness of 22 with systolic anterior motion of the mitral valve, moderate MR, a gradient to 50 at rest that goes up to 80 with Valsalva. And again, the next question will be about management. What should we do with this woman? Divergence of opinion. Okay, excellent. So the first few slides are going to kind of frame how we're going to go about this talk. So first of all, we're focusing on hypertrophic cardiomyopathy, and the usual diagnostic pathway is echo and ECG make up the foundation of making the initial diagnosis. If you can't confirm the diagnosis with those things, then we're typically going to CMR as a way to help confirm the diagnosis for most patients. And once you do have a confirmed diagnosis of HCM, there are 3 major areas that we want to address with patients, and that is the genetic and familial aspect of HCM, their risk for dying from HCM suddenly, and then chronic management of patients with symptoms. So hypertrophic cardiomyopathy is a genetic predisposition to the heart muscle being too thick, generally thought to affect 1 in 500 people around the world with autosomal dominant genetics. It is characterized at the macro level by hypertrophy of any part or the entire left ventricle, and microscopically by the myocyte disarray as shown there in the H&E stain. Here's the echocardiographic features that we're familiar with, the parasternal long axis. Most patients probably have septal hypertrophy as the typical distribution. That one shows systolic anterior motion of the mitral valve. And here on the right is the CMR. Similar view showing hypertrophy of the whole ventricle. Now, there is a differential diagnosis when you have someone with thick walls in adults. These are some of the more common things that might cause thick walls. Most of that bottom half of the last 5 bullets would have other associated signs, symptoms, organs affected, whereas HCM or LVH, say from hypertension or something, are usually more isolated. HCM is also particularly unique in its asymmetric distribution of the hypertrophy. This is the what I say that all of our patients that come to our clinic should walk away from the clinic understanding. It's actually how I have framed the rest of this talk. So again, we talked about prevalence, we'll talk about family. And then there are a few critical decisions that each patient has to come to, and that is, how are they going to screen their family? Do they want a defibrillator? What kind of therapies do they need? And then the continuing controversy over how much exercise or competition is allowed for patients with hypertrophic cardiomyopathy. So starting with family, again, we know that there's a large body of knowledge around the genetics of hypertrophic cardiomyopathy, largely centered around the cardiac sarcomere. And that is a test that can be offered to every patient to help screen their family members. In the US, genetic testing causes some challenges, in part because many insurance plans don't cover the cost of genetic testing for patients. And if patients are found to have genetic test results that are positive, it might infect their insurance rates going forward. So there's some disincentive to patients doing genetic testing. So traditionally, if a patient declines genetic testing, or if no pathogenic or likely pathogenic variants are found, they go into a cardiac imaging strategy to screen their families. Typically, we're recommending repeat screening every 5 years for adults and every 1 to 2 years in children and adolescents who are entered screening. If a pathogenic or likely pathogenic variant, that's the LP there, are identified, then you do cascade genetic testing of the family members. This seems really simple, but now we've come to the era where variants are being reclassified, which makes this not so simple. So now you have to periodically go back and reassess whether that variant has been upgraded or downgraded from its prior status, which then might kick the patient into the other screening algorithm. So the genetics have not made things particularly easy in the last few years because of this issue of us not understanding the true pathogenicity of some of the variants. Turning to sudden cardiac death risk, which maybe is the most controversial subject in hypertrophic cardiomyopathy, there's been a lot of data, a lot of risk markers studied over the years. Those in the blue boxes have more traditionally been identified as those things that have the most legs in terms of having independent status with or independent association with sudden cardiac death. Outflow tract obstruction does have good data, but it's a number that changes every minute. And so it's a highly variable risk factor. Fibrosis or scarring, as evidenced by late gadolinium enhancement on cardiac MRI, has gained more traction as an independent risk factor, particularly when there's a lot of enhancement, not just a little bit of gadolinium. And then in the upper right, younger patients have higher risk than older patients do. There is the issue of left ventricular aneurysms, which increase the scar burden in the ventricle and represent a source for ventricular tachycardia. And then other markers of just bad phenotype. So a young person with a bad phenotype is someone who should perk up your radar in terms of having higher risk. Also, the blood pressure response to exercise seems to have lost favor, maybe in part just because of logistically it's a little bit more difficult to get and doesn't seem to have as much weight as the other risk markers. So this is kind of the checklist of things that we're assessing presently to help counsel someone on their risk and help them make a decision about a defibrillator. One important aspect when you're looking at left ventricular wall thickness, it probably does make a case for multimodality imaging. So on the bottom axis is wall thickness by echo, on the y-axis is wall thickness by echo on the vertical axis, echo on MRI on the horizontal axis, and you can see they don't always match in identifying who has the highest wall thickness, and there's actually quite a bit of spread even around individual wall thicknesses. So probably you want to get both techniques, unless someone's already identified as having very thick heart muscle by one already, but you will miss patients who might otherwise be deemed as having increased wall thickness. The other thing we should do is remember not to get locked into just numeric or binary assessments and take a step back and consider the patient generally. Are there extraordinary circumstances in their family history? I'll show you a case later on of someone who has a particularly extraordinary family history that would be hard to account for in this checkbox mentality. Are they young with a particularly severe phenotype? That's a higher risk patient. Are there social determinants of health at play that you need to consider? And how many years at risk do they really have? So the patient needs to participate in this decision, not just a checkbox that indicates yes or no based on dogma. There's been 2011 guidelines in the US, 2014 guidelines in Europe, that people like to make a lot of issues that there's large discrepancies between these. I think they represent an evolution of our thought processes, and I think they can be used together. So this is the 2011 ACC guidelines that identified risk factors and then put this large gray box in the middle that said if there's these other things that are near risk factors or other considerations that could elevate a person's class of recommendation for a defibrillator. But this is largely binary and didn't take continuous variables continuously, which means we drew arbitrary cutoff values to make determinations like a wall thickness of 30 millimeters. Well, any imager knows there's no difference between 28 and 31, but yet that throws you into a completely different class of recommendation if you look at it that way. So the European guidelines introduced this great risk tool, which I use with all of my patients, that considers continuous variables continuously and gives you what I think is really important for patients, and that is an ability to frame the magnitude of their risk over the next 5 years. Because when we say to a patient, you have risk markers, their first question is, well, how high is that risk? And now we have a methodology that we can do that. As Perry knows, I'm not a particular fan of the 4 and 6% cutoffs, because I think those, again, represent arbitrary lines in the sand that doesn't allow the patient to say what their risk tolerance is, but you also aren't locked into anything. The language used there are generally indicated and generally not indicated means there is freedom of thought and discussion between you as the physician and the patient and what they want to do. There's also not that much discrepancy between these guidelines. So this is unpublished data from the Mayo Clinic showing that in most patients there is complete concordance in recommendation of patients that are in the guidelines. In some there is a one class difference, kind of intermediate or high. And the minority of patients would be completely polar recommendations, but those are entirely predictable of who they would be. In the upper left-hand corner, those where they had a class 2A indication from the ACC guidelines and were deemed low risk by the calculator, those are elderly patients with a single binary risk factor. And that's a conversation that is always nuanced and never black and white with a patient. And it's the opposite down here. These are young patients who have near risk factors by the ACC binary thing. And so again, if you have a 19-year-old with 27 millimeters of hypertrophy, you're worried about that person even though they don't have a technical risk marker by the ACC criteria. So I don't think there's as much difference in these as has been made out at every national meeting that's gone on. And in fact, I'm speaking at the American College of Cardiology in another debate about how to apply these guidelines. And I guess I'm the European representative at that conversation. So just want to point out that risk stratification, I'm on my soapbox here. So the risk stratification is an imperfect science, right? This is population statistics that you're trying to interpret down to an individual making a decision. That decision is actually the patient's decision to make. And our job is to fully inform them so they can make a decision that means the most for themselves and their family. This is illustrated in these 5 patients. Pre-2011, we were in the era of debating how many risk factors it took to warrant a defibrillator, and whether you lived in North America or Europe, you might get different recommendations for defibrillators. Then the 2011 guidelines came out, and then the ESC guidelines came out. So these are 5 patients. Now that first patient is a 23-year-old woman. She has a positive family history. That's a yes or no box on both of our guidelines. But the reality is she has 11 affected family members with HCM, and 10 of them have had ventricular arrhythmic events. That's not just a yes or no, that's a major yes. So this is where you have to consider the individual patient. All of those patients chose not to get an ICD, actually, and the bottom 2 suffered, died from sudden cardiac death. So again, each of these patients made a decision that was based on information before them, and each of them are actually okay, their family is actually okay with the decision. The bottom one here, though, is to point out that people with 0 risk factors can still have bad outcomes. There is no 0 risk group, and that's part of the nuances of this discussion. So do not use these tools to say yes or no with patients. Use these tools to have a conversation with patients about what their desire is. All right, let's move on and talk about medical and interventional therapy for patients with symptoms in HCM. The pathophysiology of the symptoms is diastolic dysfunction in almost every patient with HCM and left ventricular outflow tract obstruction in about 2/3 of patients. That obstruction causes subendocardial ischemia, it causes mitral regurgitation, and can decrease forward output, leading to the symptoms of effort-related dyspnea, angina, and sometimes presyncope. Unlike the aortic stenosis that I talked about this morning, these symptoms vary day to day. They vary how warm it is, how much food the patients had to eat, how hydrated they are, how much sodium they've had. Patients will have good days where they can feel like they can do almost anything, and other days where they have a hard time walking up a flight of stairs. And that's one of the clues that should make you think of a dynamic outflow tract obstruction and HCM if you're examining a patient. This obstruction gets worse in states of high contractility or decreased preload or afterload. All of those things happen when a person stands up and walks, which means that the patient's gradient is lowest when they're getting their echocardiogram. Their gradient is higher once they've left the echocardiographic suite and are going to their car, which means if you get a low gradient in the echocardiogram suite, you should be doing something to provoke them to see if they have a tendency to get a provocable outflow tract obstruction, to understand their effort-related gradients. We deem people as obstructive if they have a gradient document of at least 30 millimeters of mercury. But we really think it takes higher gradients than that to cause symptoms that get to class 2 or 3 levels. What that means is if you have a patient who has class 3 dyspnea and you only get a gradient of 30 at rest and with provocation, you should be looking for other causes of dyspnea for that person. Now, the outflow tract obstruction is caused by the flow having to go around this hypertrophied septum. It goes across the mitral valve, pushes that anterior leaflet in the outflow tract obstruction, narrowing the outflow tract and opening the ventricle to posteriorly directed mitral regurgitation. When examining patients for this, I really focus on our echo lab that they really have to show us the 2D function and not just the Doppler. We want to see how the mitral valve moves. Is there really SAM there? And when you go back to provoke a patient with Valsalva or squat to stand or exercise, you want to make sure that you go back and show the 2D to show that there is systolic anterior motion in the mitral valve. And importantly, that there's an open ventricle here. So this is the mitral valve touching the ventricular septum, and there's an open cavity here, which means this is true obstruction here. If the ventricle is completely empty, an EF of close to 100%, you're not talking about outflow tract obstruction there. You're talking about hyperdynamic function, and that's probably treated slightly differently. If obstruction goes up with contractility and up with decreasing loading conditions, then you do the opposite to try to treat symptoms. And many patients, most patients can be treated pharmacologically for their outflow tract obstruction. The primary therapies are beta blockers, followed by the non-dihydropyridine class calcium channel blockers. Disopyramide can be added to one of those other agents. Usually should be added to something that blocks the AV node just so that they don't get rapid conduction should they go into AFib. It has a success rate purported to be as high as 60 to 70% in patients who have not had satisfactory reduction in their symptoms with one of the other agents. We like to avoid pure vasodilator therapy in patients because, again, afterload reduction can make them much more prone to outflow tract obstruction in their symptoms. And we emphasize it's important for patients to stay hydrated and or avoid high-dose diuretics as part of treatment of other conditions they may have. Success of medical therapy is determined by the patient, not the echocardiogram. So again, if the patient feels better since you made a change in their medications, that's success. The effect of medications is symptom-based relief, not changing natural history of HCM. So don't use the gradient you get in the echocardiogram to define success. Ask the patient how they're doing. Even in our highly biased referral population, so people come to see us because of our surgical success, we send most away with successful management with medications, even though they've been deemed as medical failures before they come here. So you can do much with adjusting their medications appropriately and not have to necessarily do an intervention. But there are those patients who are going to fail medical therapy. They still have symptoms despite adequate medical therapy, or you've added side effects that are just as bad as the original symptoms. And those are patients who would then become candidates for either myectomy or ablation. Myectomy has been around since the late 1950s. Operative mortality is now approaching 0.5% in the high volume centers in the US. The gradient is virtually abolished. Success rates are around 90 to 95%, rendering patients class 1 to 2 when they were class 3 to 4 to begin with. Survival following myectomy is equivalent to age-matched general population in the US, and it appears the rate of appropriate ICD discharges is lower in patients who have had surgery than those who are managed without any procedures. So we feel good about that when it's done in high-volume centers with these excellent results. Ablation is also very effective. It reduces the gradient tremendously, has excellent improvement in NYHA class. The complication rates have tremendously improved with advancement of the technique and lower alcohol doses. And the mortality rates are now similar to what we're seeing in myectomy. In our data at Mayo, of all the patients treated, the symptom-free survival is equivalent between the two procedures. If we just limit the evaluation to those who are younger, under the age of 65, myectomy appears to be slightly more durable for those patients. Not sure we have a great explanation for why that might be. So if you look at a checklist of the things that patients are interested in and doctors are interested in between the two procedures, there are some advantages and disadvantages of each of these procedures for individual patients. Moving on to non-obstructive HCM. So apical HCM, often we think there gets to be subendocardial ischemia here, which over time might cause some scarring in the development of an apical aneurysm. These patients do not generally have outflow tract obstruction. That's why they're called non-obstructive. Conceptually, the risk stratification is not different for patient without obstruction. Conceptually, you use medical therapy to treat symptoms. It just might be different drugs. You aren't limited to just those 3 or 4 medications because you don't have to worry about outflow tract obstruction. So you can use vasodilators and diuretics if that is the appropriate medication you think for the symptoms the patient is presenting with. The interventions that we use for patients with non-obstructive HCM are different. You might consider CRT if patients have a low EF. You might consider transplant for patients with advanced heart failure symptoms. But we also have been doing a novel procedure for patients with severe apical hypertrophy and almost no cavity, doing an apical myectomy. And I'll show you a case this evening of this. But you can see that following this procedure, EDP is lower and the stroke volume is higher. So these patients who would have been only candidates for transplant prior to the introduction of this procedure now can consider something short of getting someone else's heart as an option that has some success. So non-obstructive HCM, no symptoms, no meds. If they have heart failure, treat them as if they have HFpEF. If they have angina, use antianginals. You can consider this apical myectomy if they have a very small end-diastolic volume or no stroke volume reserve, and they are candidates for advanced heart failure therapies. So let's go back to our questions. This first one, the 36-year-old male with dyspnea and no outflow tract obstruction on his initial exam. So the thing I was looking for most was, this is the guy who needs to have a provocative test. Our standard echo at Mayo includes Valsalva maneuver, doing some squat to stand in the echo lab and examining the patient, imaging the patient when they're upright, or you can use stress echocardiography to try to identify this obstruction. But that's important for this guy because he's got dyspnea and so far no obstruction. But if he has obstruction, then you know how you want to treat him next. This patient, the 64-year-old woman, to me, the best thing to do for this person is to take this agent away. It's a pure vasodilator that's making her outflow tract obstruction more prominent. And if you need to do something to manage your blood pressure after that, then maybe you consider introducing either one of the other calcium channel blockers or the beta blocker next. So sometimes you get very successful results by taking medications away and not just by what you add. So in summary, in a couple of slides, remember this basic concept. It's ECG and echo to make the diagnosis in most people. Sometimes you need cardiac MRI for that confirmation. You're going to discuss family screening, sudden cardiac death risk assessment, and this is a summary slide of how you manage patients and follow patients. Asymptomatic patients you want to see back every few years. You might consider stress testing if you can't tell what their symptom status is like. And if they don't already have a defibrillator, you might consider repeating the CMR every 3 to 5 years to look for that gadolinium enhancement. And then we talked about obstruction. So thank you very much.
Thank you. Another